Each week we gather for class and we try to learn something new. We try to learn something that may seem easy to some and difficult to others. For me, my newest hobby is trying to learn to play a guitar that my husband gave me many years ago. And the interesting part is that it's a difficult task for me, but it's difficult because it's new. I will probably look back someday, 20 years from now, maybe, and I will think, why did I think that was so difficult? So, for some, understanding healthcare economics can be difficult as a nurse, but it's something that we should have at least a fundamental understanding of. And one of the things that I think it's important for us to understand is moral hazards. Moral hazards, the tendency for insurance against loss to reduce incentives to prevent or minimize cost of that loss. And we think about it all the time, and there are many things we do that we buy insurance for because we know in reality that we could not afford it if we had to pay all the cost out of pocket. One example that's common to all of us is our car insurance. It's not just that we couldn't afford to replace the cost of our car, but God forbid we injure someone else and cause them serious bodily harm. We would never be able to pay for their health care or all of their needs. And as a consequence, we choose to have insurance. And that insurance makes it possible for us to cover those costs. Now, some people may say, well, the insurance also makes it possible for us to be a little more reckless. And in some cases, insurance companies put little things in place to make sure we aren't. So my car insurance, if I get speeding tickets because I'm driving too fast or driving recklessly, my car insurance would go way up. And it would go up because I was being unsafe. And you put things like that in place so we don't think that the insurance basically allows us to act in a way that we shouldn't act. We should ask ourselves, what if we consider access to care without considering the moral hazards? And if we do consider just access to care as our priority, then we might ask ourselves some questions. And those questions might be about individual choice. So we might think about how individuals express preferences about accessing health care that may be influenced by social choice and public policy. We may want to know, how does personal preference, social choice, and public policy interact? Should preference affect the design of the healthcare system, including insurance, to maximize access to care and improve outcomes? One way to think about this is, should the doctor's offices, the nurse practitioner's offices, be opened at times that make it maximally convenient for me to go, rather than me having to take off work to go and thus increasing my cost? What if instead they had before dawn hours, or they had an evening shift so that I could go for routine care after 5 in the evening? It makes my life more convenient. It certainly doesn't make the provider's life more convenient. And what if in access to care, things that could be handled via telemedicine, I could video in from my office, answer the questions that need to be answered, tell them the routine things that you could get by an attachment to your iPhone. and not have to go in at all. Would that not make life more convenient? On the other hand, would it make me more likely to use more services? But again, we're only considering access to care. What implications does personal preference have on the system design and outcomes? Well, certainly for some people it has a lot. If you want to pay for Cadillac Care and you want to pay out of pocket, your preferences have a lot of impact on the design of that care. But what if you're poor? Do the health clinics, the federally funded or federally qualified health centers, or the not-for-profit health centers, or the ones run by charitable organizations, do they do the same things to make sure that their clients' preferences are respected and considered? And then, can healthcare systems change to improve access to care and increase life expectancy or quality of life? And I think that there is probably not a single provider in the United States that does not know that for what we charge people and for what they pay, the outcomes in the U.S. are unacceptable. The quality does not meet the price people pay for. But now let's add in the concept of moral hazard as a consideration. And there are 5 things that you must consider. And here are the 5 things. An individual faces some risk of a bad event, X, happening, and their actions can increase or decrease the likelihood of that event happening. And the textbook that I use for this class gives an example that just shoots right to my heart about the love of cheeseburgers and the known cardiac risk that I have in my family history. So as much as I love a cheeseburger, I should not eat a cheeseburger. So the consequence is, if my insurance is going to cover the cost of my cardiac cath someday, is it okay for me to go ahead and eat those cheeseburgers? Because I could just ask them to, give me more medications, another statin, add a little more, and go ahead and eat that cheeseburger. Now, I can feel some of you cringing that I said that. But don't think that there aren't people that think, oh, I'm taking my statin, I can have another cheeseburger. I took my insulin, I'm okay to have a donut. It is a consideration. So the individual buys an insurance contract or an insurance policy that will help pay some or all of the cost of X if it occurs. The price of X to the individual is now lower. And so the price distortion means the individual does not face all the consequences of eating that donut or that cheeseburger, or not going to the gym. In response to the price distortion, the individual changes their behavior in a way that increases the chances of X or increases the cost of recovering for X. Now let me give you an example of this that is not related to insurance. In many ways it is. It's about vaccinations. As nurse practitioners, most of us are very passionate about all teenagers getting the HPV vaccine because we do not want to see young women getting cervical cancer. Nor do we want to see young men spreading HPV to young women and thus them getting cervical cancer someday. So we very much push that vaccine, but there are parents that are afraid that by taking that vaccine, that young girl will then think, I don't have the same risk from having sex, so now I'm more likely to have sex. So I'm a skeptic. I don't believe that for several reasons. One, because I don't think teenagers put that much thought into why they don't have sex or do have sex. I think that they are strictly driven by hormones, and occasionally moral teachings, weigh in. But for the most part, they're not considering that I'm not going to get cervical cancer someday. They're considering whether or not they're going to lose a boyfriend or a girlfriend. So, in many ways, sometimes people use this in a way it probably shouldn't be used. The insurance company cannot possibly observe this behavior change because there's an information asymmetry. Otherwise, the contract would have been written to discourage or penalize the riskier behavior, just like her car insurance contracts do. If we speed and we get a ticket, our insurance goes up, but my health insurance doesn't go up if I eat that cheeseburger. Now, some insurance policies actually do decrease the cost if you engage in certain healthy behaviors. And then, finally, the individual's risky behavior creates a social loss because the costly event X occurs more than it would have without insurance. An example that I will use in this presentation about this is related to disasters and disaster insurance or flood insurance. And in many cases, that is a really good example of a moral hazard. So when you're considering this, we need to consider two things. First of all, a little background. Disasters in developing nations are very different than disasters in developed nations. So the US being a developed nation, Haiti being a developing nation, for example. In a developing nation, there's an average of 1,000 deaths per disaster. 96% of all the deaths come from natural disasters, and they cost less than $100 million in losses. The consequences, long-term development retardation and per capita catastrophe burden is dramatically higher. Whereas in a developed nation like the US, the average loss of life is less than 10 deaths. There's generally over $600 million in losses per disaster, and that is ever increasing now. And there is a relatively quick recovery in comparison. So, for example, in Nicaragua after Hurricane Mitch, 20 years later, it had been set back so far that, they were looking like a 20-year delay in where they actually were. But one of the things that we find in disasters is that sometimes we do things that make the cost of these disasters in developed nations like ours higher. So we sell flood insurance because people choose to build in floodplains. We could choose not to build in floodplains and make it less likely to suffer those consequences. Likewise, we have disaster insurance for hotels and homeowners of people that choose to build on the Gulf Coast or on the coast in Florida, knowing that the risk of a hurricane is not only real, but it is a substantial risk. And so the cost of that disaster will actually be much higher because we've sold people insurance that makes them more likely to build a house in this place that's highly risky. Some examples, this is just some examples of the different types of hurricanes and or disasters, natural disasters and things that happen and the losses that occur. It's not just the losses in housing or industry or commerce, but there's also breakdowns in communication, and there's social disruption in people's educations, disruption in healthcare, and other factors. Let us consider a few other things. Poorly diversified economies are more vulnerable than diverse economies. So the US has a fairly diverse economy. We're not as vulnerable as an economy that depends strictly on agriculture. Economies with infrastructure that is concentrated in a geographical area are also more vulnerable than economies with diffuse infrastructures. Let me give you another example to consider. And this is with foreign aid. And this is maybe a moral hazard, maybe an unintended consequence. Maybe it's just governmental failures, or maybe it's just simply bad policy. But one of the things we know is that when there's a disaster in a developing country, people tend to want to send money or financial aid. It can take the governments months to negotiate that, and then it can take more months for the money to even flow. We know that food relief aid is unpredictable, and it ebbs and flows based on largely the CNN effect, which is as long as something's getting a lot of attention on CNN, the more likely that people are to be charitable and give. But once there is no attention, then all of a sudden you lose the impact. And then there's the issue of soft loans, and these are related to debt burdens in the developing world that contribute to their vulnerability. For example, before Hurricane Mitch in Nicaragua, they spent about $220 million in debt servicing, which is over 2 times their combined budgets for health and education. So let's think now then about mitigation of some of those moral hazards that may exist. Let's think about structural considerations. People may build physical barriers, so things that are visible. And we're living here in Missouri and St. Louis, and there are flood walls. And the flood walls are visible in most cities along the Mississippi River. They are a good move politically. They are expensive. But in many ways, while they can be effective for the average flood, they're going to be relatively ineffective in some low-lying areas, because what they do is they push the waters downstream to someplace that couldn't afford the flood wall. And now you may say, well, it's a rural area, it's not as big of a city, so the impact isn't the same, but that means that you're considering the impact on the people who may be poor to be less important than the impact on people that have more. It's a consideration. So what it does is it shifts capital to risk-prone areas. So it shifts also the risk to other areas. Some non-structural things that are actually somewhat more effective are zoning. When a disaster occurs and there's a major flood, you rezone so that people don't rebuild in the flood zone. You buy them out. In earthquake-prone areas, you put in building codes that make sure the structures are more stable during an earthquake. I recently heard a segment on the news here in St. Louis, maybe a week or two ago, and the person was talking about part of the problem of the expense of housing is the building codes, and you want to say yes, and the reason we don't have as many people dying in building collapses during disasters is because of those very building codes. And then building inspections. They're cheap, they're effective, frequently a poor political move because nobody likes to be told that your house didn't pass inspection. And there's little donor support for them because, again, when I go to sell my house, if there's something wrong with it that they're going to ask me to fix, then I'm going to be unhappy because it cost me money, even though I may intellectually recognize it's the right thing. There are values that we have to consider other than efficiency, and one of those that we must consider is human dignity. We need to know that all things are not equal for all people, and that whenever we are considering the moral hazards that may be brought on by insurance, whether it be on our cars or whether it be for health insurance, we need to respect the dignity for others. What did we do prior to government involvement in social welfare in the 1930s? And the truth is, people starved and people died. And today, we consider that unacceptable. And does that mean we have to tolerate some moral hazards? Yes, it does. What policies help to increase one's ability to change preferences into allocation of resources? How do we do that? How do we make the mom prefer to have the HPV vaccine for her child? How do we encourage the middle-aged person to buy long-term care insurance, knowing that when you get older, you will need it? And only 10% of Americans currently have it. And yet we know the astronomical cost of long-term care. What policies help to increase participation in the system by which people are elected? These are the people that actually make the policies that can change healthcare. And if we're not participating in our democracy, we're abdicating our responsibility to make change and to improve the quality of care. And at what point is paternalism desired? As healthcare providers, we all have to address this question every day. And it's something you need to know the answer to. So what constitutes dignified survival? Is it access to care? Does the level of income influence our access to care? And certainly we know that with the Affordable Care Act, that was one measure to level the playing field for everyone. It made it possible for 90% of all Americans to actually have health insurance. And while we may say you can get emergency care without health insurance, what you couldn't get was routine care and sometimes life-saving care in the cases of cancer and other illnesses. We have to ask ourselves, does $100 mean as much to me as it does to the average college student? Does insurance balance the scales? And at what income does one qualify for government aid? This is something that as providers, especially advanced practice nurses, you need to know these policies very well. You need to know how to help your patients access care. And then you have to understand taxes and the tax codes. Those with higher income pay more to keep the utility function equal. So if I'm paying 25%, 25% to me is not the same, does not feel the same as 25% to a billionaire, because they can pay 25% of their income and they're still going to have more money than I make in a year. Likewise, I can pay 25% of my income and I'm still going to have more income than a person living in poverty makes in a year. It is taxes that help support the healthcare system. And then we have to think about societal values, including laws and social norms, and how they impact access to care. We could say that some of this comes from government failures, but the truth is, whether it's a direct democracy or not, people argue about this sometimes, but direct democracy encourages learning about public affairs and being more willing to accept social choice that they opposed. Representative governments, or when elected officials of the executive, legislative, and judicial branches, basically get to make a lot of decisions for us. Failure occurs when the votes are influenced by financial incentives. contributions, or even bribes. And I think a lot of us look at our elected representatives and we do think they're unduly influenced by large corporations and by people that have money to donate. But that being said, a voice and knowledge matters. So your voice to your representatives matters. But more important than that, your advocacy for your patients, knowing what actually exists and how to inform your patients about things like an importance of an HPV vaccine or access to long-term care, what it's going to cost them someday, and talking to them about it while they're young enough to actually easily get that insurance. That's an important aspect of what it means to be a professional. A couple of paradoxes for your consideration. The self-development paradox says that in trying to make hazardous areas safer, the federal government increases the potential for catastrophic damage. And then the local government paradox is that local citizens bear the brunt of human suffering and economic loss in a disaster, but local officials pay little attention to mitigation. You could take either one of these and you can change the words from a disaster to whatever aspect of healthcare you're involved in. And then try to say, how will that change my practice? I always like to end with this slide, and I want to end with it for a reason. What this shows is it basically shows significant events in the United States that occurred, and at the same time, it's showing this. What you get is consumer confidence over time. So you will notice that you have the Cuban Missile Crisis and consumer confidence is low. Or the Oklahoma City bombing, consumer confidence is low. And then it goes back up. We have to consider being knowledgeable of the cycles that are occurring within our economy and within the way we look at things around us, and know that there is an impact. These are just some things for you to think about as you enter this week's readings and this week's exercises. And hopefully it will give you a slightly broader perspective as you read the chapters and the articles, and as if you watch the videos that are included. Remembering that the more knowledgeable you are, the better able you will be to inform your patients and to help them make the best possible choices.